Senate Standing Committee on the Health Services. Appreciate everyone braving the elements once again. Special recognition to my good friend Senator Judy Rocky Adams, who always a challenge to get here at 8 o'clock in the morning, but she was one of the first. I appreciate her being here. Anyone have any guests you want to recognize this morning? Seeing none, we'll go straight to roll call.
Senator Rocky Adams.
Here.
Senator Berg. Senator Carroll.
Here.
Senator Douglas. Senator Herron. Senator Mills. Senator Nemes.
Present.
Senator Rawlings.
Present.
Senator Tishner. Vice Chair Richardson.
Here.
Chairman Meredith.
Present. We do have a quorum and duly constituted to conduct business, so we'll jump right into the agenda. Our first and only bill today is Senate Bill 18, and our co-chair is rushing to the table.
Don't put your foot in your mouth this morning. There we go.
Thank you, Senator Carroll. That was clever.
Gentlemen, you know the routine. If you would, please identify yourself for your record, and I believe we have someone on Zoom as well, and I don't know how you want to handle that, Senator, whether he want to introduce himself or you want to introduce, but just feel free to proceed.
Good morning, Mr. Chairman, members of the committee. I am Senator Richardson from District 3.
Good morning. My name is Tom Underwood. I'm the Executive Director of the Kentucky Podiatric Medical Association.
Go ahead, Dr. Roberts.
Good morning, all. My name is Jerry Roberts. I'm a podiatrist in Somerset, Kentucky, president of the KPMA.
Thank you, Dr. Roberts. Mr. Chairman, this morning before we get started, there is a committee substitute that I think we need to take.
There's a motion to approve substitute.
So moved.
So moved. Second? Second. All in favor say aye.
Aye.
Any opposition? Being none, approved. Thank you. Please proceed.
Thank you so much. Mr. Chairman, Senate Bill 18 is a straightforward modernization of Kentucky's podiatry laws. It does not expand the scope of podiatry practice. Instead, it updates outdated statutes so our laws match how foot and ankle care is already delivered safely across the country. First, the bill formally recognizes roles that already exist in modern clinics: podiatric assistants, podiatric residents, and supervising podiatrists, and gives the State Board of Podiatry clear authority to license and regulate them. This closes gaps in current law and ensures consistent oversight. Second, Senate Bill 18 allows, for the first time, a podiatrist to supervise a physician assistant within podiatry practices. That supervision requires approval from both the Board of Medical Licensure and the Board of Podiatry, with a detailed application outlining scope, communication, and review procedures. A podiatrist may supervise no more than 4 physicians assistants, and each must be individually approved. Third, the bill codifies modern training standards by requiring new podiatrists licensed after January 1st, 2027 to complete at least 2 years of podiatric residency. Finally, it extends disciplinary authority to all these new license categories so accountability exists across the entire podiatric care team. The result is simple: better access to foot and ankle care, clearer rules for providers, and stronger patient protections without spanning the scope of practice. At this time, I would like to turn some time over to Dr. Roberts to speak professionally about this bill.
Good morning, and thank you for letting me appear remotely this morning. Podiatry is not just foot care, but a medical and surgical specialty, plays a critical role in mobility, workforce participation, injury recovery, and prevention of disability across the Commonwealth. The human foot is very complex. It contains 26 bones, more than 30 joints, and podiatry is a specialty solely dedicated to the diagnosis and treatment of diseases of the foot. Foot and ankle traumas are among the most common injuries seen after fall, motor vehicle accidents, and workplace injuries that comprise a large part of our practice, as well as playing a role in sports medicine and rehabilitation. one of the focuses of my practice deals with the diabetic population. Diabetes is a major health challenge and an expensive one in Kentucky. Approximately 1 in 8 adults in our state have diagnosis of diabetes. The cost of amputations, both in workplace productivity and in healthcare costs, as well as the overall health of our population, is can be extremely devastating. And that is a large part of the majority of our practices is to help prevent these amputations, address the biomechanical issues of a diabetic patient, to keep them active and healthier. Regarding our education, podiatrists are physicians and surgeons who complete 4 years of undergraduate education, 4 years of podiatric medical education, and the current model is 3 years of a hospital-based surgical residency and then an opportunity for fellowship training, very similar to the American Board of Medical Specialties 443 model. Fellowship training exists in limb deformity correction, trauma, wound care, a variety of other unique, highly specialized areas. Kentucky does lag behind other states in not requiring a completion of residency program prior to receiving a full license. In our adjacent states, there are Ohio calls it a training certificate, but there's essentially a provisional license that you obtain as a resident that allows you to practice within the scope of your training while you are being supervised by a fully licensed physician. From a policy standpoint, podiatry delivers measurable value through fewer emergency visits, fewer amputations, faster return to work, and lower long-term disability costs. I would appreciate your help and support, and I'll be happy to answer any questions that I can.
Mr. Chairman, if there are no questions, respectfully ask for a motion on this bill.
Thank you. This is Health Services. We always have questions. So,
I understand.
Senator Byrd, you're first in the queue, and thank you for being here this morning.
Good morning. Good morning. My question has to do with the definition of supervision, which is a problem that we seem to be having across a lot of legislation this session. When you all talk about supervising, a podiatrist supervising for physician assistants, what does that require of that supervising physician? Do they have to be available in person? Do they have to be available within 30 minutes? Do they have to be available by phone? What is the requirement of a supervising physician?
Dr. Roberts, would you like to take that one?
Sure. There are 3 defined levels of supervision. There is direct, where the physician is essentially in the same room or in close proximity to the supervisee. And then there are varying levels of indirect, meaning they're either in the same building or they are available at all times by telephone in order to answer any questions that arise if a procedure or a patient were to become more complicated. And I know supervision is kind of a murky term, as it has been for a number of specialties and situations. But in this case, I think either of any of those definitions of supervision would be applicable.
Follow up? Yes.
All right, so when we're not talking about direct supervision being required, but you're asking for indirect supervision, which means simply available for a phone call?
That would be correct. with the technological, advances that we have, I mean, you also have video conference. You have the ability to review, medical records or imaging studies, assisted by technology. But again, the purpose of there are a number of roles that PAs can be utilized and are currently utilized in, kind of across the state. The our my practice has a number of locations throughout Kentucky. The we have endeavored to expand our coverage into Eastern Kentucky, where there are very few podiatrists and extremely high need for foot and ankle services. Um, my a portion of my desire to bring PAs into our uh, specialty is to be able to expand into areas that are difficult to provide direct physician coverage. Now, in this instance, that would require indirect supervision.
Mr. Chairman, if I could address Senator Berg's question as well. We did take the exact language from the allopathic sections on a PA supervision and all. So that was not essentially new language. We did mirror that, and we have stayed in contact with the Kentucky Medical Association.
Thank you. Honestly, with podiatry, it's hard to figure out what could be a life-threatening emergency unless you accidentally sever an artery. So, I mean, indirect supervision in that case would not be unreasonable, in my opinion. I just would like it to be clearly defined what the expectation is. Thank you.
Senator Nemus.
Yes, thank you, Mr. Chairman. I'm assuming there's already a board of podiatry. We're not going to add to that.
No, sir, there has been one for about
But we
4
are going to
years.
add new certs and podiatric assistant is something new.
Yes, sir, that's for the office staff so that there could
Okay,
be
so we have people doing the job, but we're going to make them or require them to get education in that and get a certification. Is that going to raise costs, and will insurance cover that?
The anticipation is that the role of those office assistants won't essentially change, nor will any additional billings beyond that. But it will be an opportunity to make sure that the office assistants have training in their role.
Thank you.
I think I'm a little murky. We're looking at podiatric assistants. Is that that's what we're looking at, or at least we're having a conversation about? And as Senator Berg had asked, we between being direct and indirect supervisions, are we are the assistants now charging E&M codes under the surgical coverage?
No, sir.
Okay. Will this bill change that?
No, sir. Primarily what we're looking for with regard to PA solutions on this, a lot of our physicians do emergency room work, and there are PAs that are working in the emergency room, and currently they're not able to use the PAs. So that's part of the thing is in a hospital setting.
Well, but my question is simply, will this allow a PA to charge under a surgical E&M code?
As they currently do with allopathic, it would be the same.
So that doesn't answer my question. It is a yes or no question.
Okay?
Does this allow the PAs to now start charging under a surgical code? It's just a yes or no question.
It would be a yes or no if I knew the answer, sir.
Okay, so we don't know yet.
Well, Dr. Roberts, can you speak to that at all?
So, for physician assistants, yes, it would, as they do with other specialties. For clarity, there are and unfortunately, it's just a nomenclature thing, a little bit of alliteration, but we're looking at allowing podiatrists to supervise physician assistants. Additionally, we are creating the role of podiatric medical assistants. So the podiatric medical assistants, which are office staff, will not be able to bill certain. Their role will remain unchanged. The services would be performed and billed by the by the podiatrist. Now, when it comes to physician assistants, and of course these are physician assistants who are licensed through I believe it's the Kentucky Physician Assistant. Help me out, Tom.
I believe they're under the Board of Medical Licensure, but I don't know the answer to that.
They are independently licensed outside of the podiatry board. This is just allowing physician assistants who have a Kentucky license to work as a PA to work alongside or under the supervision of podiatrists.
May I clarify, Mr. Chairman? Okay. I understand, but we're talking about direct and or indirect supervision. And my concern is, again, expansion of privileges. You know, allowing people to use similar codes to more more highly trained people. And again, as my good friend Senator Meredith has said in the past, it's not about the money, but it really is about the money. So my concern is that how we're exposing, and you're 100% right. The foot is extremely complex, doctor, and in most instances, people don't understand that the foot is actually more complex than the hand. And I'll just have to chew on this a little bit. Thank you, Mr. Chairman.
Mr. Chairman, can I address the point that Senator Douglas made, please?
Quickly.
Yes, sir. You'll find that PAs are working closely with orthopedists as well. So this is only allowing podiatric physicians to be able to work in the same vein with the PA.
Senator Adams.
Yeah, just thank you, Mr. Chairman. Just a quick question. Is the Kentucky Medical Association taking a position on this bill?
They are taking a neutral position as we have worked with them to ensure that the language is acceptable with them.
Thank you.
Thank you.
Any other questions? Seeing none, is there a motion on the bill? Motion by Senator Berg, second by Senator Adams. Please call the roll.
Senator Rocky Adams. Aye. Senator Berg.
Explain my yes vote.
Yes, ma'am.
I am going to vote yes. I do think there's a lot of really good stuff in this bill, and I do think most of it is being requested for good reasons. I am, again, concerned, and this is not specific to this bill, I am concerned about the integrity of the language and what we require. And I think supervision is too broad of a term. We know in medicine there's different types of supervision. And I would really like us to start clarifying as a group, when we require supervision, what does that mean? Because we have had abuses in this state where we've had physicians ostensibly supervising when they weren't even in the same city. And I'm talking about, podiatrists operate. They go into the operating room. Somebody with a higher level, the highest level of training, needs to be immediately available in those situations. So thank you.
Senator Carroll. Aye. Senator Douglas.
I would explain my vote.
Yes, please.
Thank you, Mr. Chairman. I find myself in the same corner as my colleague, Senator Berg. in the healthcare space, we're continually seeing expansion of technicians and others into the higher realms in terms of coding and everything else. And our patients often expect to have the highest level of trained person working on them. I've seen this creep going on since about 2013. And it really does, for those of us who are in medicine, causes pause, Mr. Chairman. And we often say it's so that we can reach more patients or we can provide a broader level of care to our healthcare deserts. Absolutely no studies, none, support that. None support that. And so I agree. I think we're going to in the future need to have a little bit more pause and take a look at what we've expanded and maybe even consider whether or not what we've given needs to be pulled back to make sure that we are getting better return on our investment and making sure that we're getting better patient outcomes, which is what we're supposed to be doing in medicine in the first place. Thank you, Mr. Chairman.
Senator Herron. Senator Mills. Senator Nemes.
Explain my aye vote, please. Yes, sir. Thank you, Mr. Chairman. I have three concerns about this. One is I feel like it's somewhat a workforce deterrent. If you have an individual go into an office and get a job to do the basic stuff and this and that, now they have to have a cert and this and that. You may, two things, deter people from getting a job, and then you have less people to do that job. It's also, as Dr. Douglas says, it feels like another encroachment on the medical doctors. Another thing is if they can bill in a certain way, it's another increase in cost. So I have those concerns, but I vote aye.
Senator Rawlings.
Explain my vote. Yes. Just going along with the dialogue here with Senator Berg, Douglas, and Nemes, I do vote yes to move it on, but I do have all of those concerns. Thank you.
Senator Richardson. Aye. Senator Tishner. Aye. Chairman Meredith.
I'm going to explain my vote as well. My interest in this is, first, it formalizes a lot of things that should have already been formalized, particularly with regard to residency requirements for podiatrists, but secondly, that how it impacts rural communities. That's where I'm always driven. And I think we've had some very spirited discussion here. I think it's interesting. We all come from a different perspective. The issues of supervision, the issues of possible encroachment on our physicians. I think interesting topic, but I think we have to understand where those come from as well. Is lack of access to care, particularly in rural communities and economically disadvantaged communities. We're not there. And I hear people constantly complaining and expressing concern about these issues, but no one rarely presents a solution to the problem. And we do have medical deserts throughout Kentucky that are quite significant, but no one wants to provide a reasonable solution how to address those. I think this is one of those. I concur with my esteemed colleague, Senator Douglas, that maybe we have gone too far, but in that the scope of all legislation we pass, there's always unintended consequences, and we need to take a look at it. But I don't know anything that's more paramount right now than trying to address access to care for rural Kentucky, so that's why I support this legislation. With that, the vote is unanimous and passes with favorable expression. Congratulations, Senator. We look forward to continued discussion on the Senate floor.
Thank you, Mr. Chairman, members of the committee.
Next, we have a presentation on outpatient pediatric therapies. I think this is a subject that most of us here on this committee have a real passion for with our children and some of the struggles we have with our therapies. Ladies, glad you could join us this morning, particularly with the inclement weather that we've encountered of late. I appreciate if you would make sure your mic is pulled very close to you. Make sure that green light is on. You push the button. And if you would, please introduce yourself for the record.
Okay, can you hear me?
Yes.
All right.
Good job.
My name is Renee Sagasser. I've met most of you guys, and I'm so thankful that you allowed me to come back today to speak to you. I'm an owner of Associates in Pediatric Therapy, and as well as the founder of Associates in Pediatric Therapy. Real quick, for those who don't know me, as a child, I was in speech therapy for many years. And so I've worked really hard on my speech myself. And then 4 out of 5 of my children have went through services within our practice for either OT, PT, or speech. So it's very dear to my heart. And my mom was also a traumatic brain injury survivor. So just a little history there. I'm going to introduce my friend. So I'm Pam Marshall. I don't know if this mic's on.
Green light needs to be on.
There we go.
Thank you.
Got it. So I'm Pam Marshall, and I am an occupational therapist. And like Renee, my husband and I have 5 children that we've raised here in Kentucky. And fun story, how I got to Kentucky, I was looking for an OT school, and I happened to be at a beach in South Carolina way back in the 80s, before cell phone and internet. And a girl walked about 2 miles to find me and told me all about this wonderful OT program at Eastern Kentucky University. And I got in my little car and packed up and went there with not knowing anyone. And now I have been here in Kentucky, just loving it since. And I've been very passionate about children my whole career. My husband and I have served children and families. And back in 2013, decided to start a practice here so I can help children. And that's
Awesome. All right. We wanted a lot of our sweet little kids to come today, but with the weather and short notice, we thought we would just share a few photos of what we do in our clinics. And they are precious, and they're the reason that we're here today. Mm-hmm. And also, like Senator Meredith, because we need increases in money. Mm-hmm. All right. I'm going to move this just so I can see my screen over here. So why this matters, access for Medicaid. Of course, we're talking about children 0 to 21. We believe that they're at risk. Medicaid, as you know, is around 60 to 70% of our pediatric population in Kentucky is on Medicaid. We are seeing a huge turnover for providers leaving pediatrics altogether. We have several of our therapists that are going to SNFs or leaving the field or going into the school systems. APT and Marshall together, we have over 5,000 children just on our waiting list waiting for pediatric therapy services in the state of Kentucky, which is a lot. There has really been no rate increase since I've opened my practice or since Pam's opened her practice.
Mm-hmm. And an interesting note along that is the requirements now. Back when I went through OT school, it was a BS. Then it moved to a master's in the 90s. Now it's doctorate level.
Doctorate.
So most of who we are hiring are doctorate level clinicians, and we're having to pay them as if they were not. So, but this, again, why this matters, when you look at the conversion factor, the Medicare conversion factor, you can see over time there's been very little increase, and largely when you add up all the decreases, overall it's been a decrease, for our services. And currently the Medicaid fee schedule, has been priced off of this conversion factor. So Kentucky, overall in our industry, we've just seen our margins continue to shrink. And as you all hear, the cost of doing business continues to rise, even across the board, from just expenses for our facilities and serving pediatrics. We tend to have larger facilities than what probably you're used to if you've gone to a physical therapy outpatient practice as an adult. They're very small footprints. We have much larger space because we need that to serve children. And then this next slide was taken from an older study, but the data still applies here. The point is, we have 1 in 11 children are 3 in 5 live in a rural area. So 3 out of 5 live in a rural area. And then out of that, 1 in 5 have 3 or more chronic conditions. So just the who we're treating are those children, and they cover children is about 46% of that Medicaid. Medicaid covers 46% of children. So that means we have a lot of Medicaid payers in our practice. On this side, really what you want to see is, on this slide, the 4%, it's a little margin, make up the overall budget for children. And then we, pediatric therapy, we're just a slice of that 4%.
Okay. So again, this issue is not new. And I want to make sure we acknowledge that we have followed this process. And I want to thank everybody who's helped us through this, because it's not like we've just all of a sudden showed up during this budget season and said we need money. We've been working on this for years. And I just wanted to give a little history there. APT, we started taking Medicaid in 2010, and then she started in 2013. In 2014 and 15 was when I first approached Commissioner Lee about the concern of the rates back in 2014 and 15. And so that was our first formal outreach to start the process to say, these rates are not significant, are not going to help us continue to grow our businesses if we cannot get an increase. In 2015, rates decreased. So that was a bummer for a lot of us. And then, of course, we know in 2021 and 2022, after we're coming out of COVID, everything rose. Everything was increasing. And then it was really putting a strain on our workforce. And we had a lot of people leave the workforce at that time for financial reasons.
Yeah. And the schools, what schools are able to pay, like an occupational therapist, speech therapist, physical therapist, is much higher, and they get more time off. So it's kind of a hard place to be.
So we took legislative action in 2023 and came before you guys and testified. And it was because of you that we were able to come up with the Senate Joint Resolution 54, which I've been very grateful for. And then what that did is that directed the DMS to examine the pediatric therapy rates and propose solutions for us.
So part of that study compared our rates in Kentucky to other states. And what we've experienced, or what was shown, is that we do have a lower fee schedule, and somehow we've been able to keep moving and serving children and really having to be creative in our workforce and creative in our approaches. The other thing that has hit both of our practices very hard is the volume of retro deactivations. So we've had, and it continues, we were assured that there was going to be a process in place. But what that looks like is when you take a child like some of those children in the picture, and they have multiple services, maybe they have cerebral palsy, they have a condition that requires, a lot of intervention. Those claims may go back a year and a half, as much as 2 years. And all of that money will be taken back. And we, the provider, have to go through a whole process then to rebill it. And so it's taken back from the MCO. We have to have the actual show that money's been taken back before we then can move forward and rebill it to the state.
And just to clarify that, it's when maybe a child was on Passport and then they changed over to a different MCO or went back on the state. And so what the state has been doing is putting it on the providers for administration burden. Then we have to rebill all those claims, even though it had nothing to do with our services. We completed the authorization. We did all of our paperwork to see that patient, and then they go back and change it.
And it's usually when they're going through disability review.
Yep.
And they'll backdate it to that date of service. And so that's been a big hardship, because as you know, when you're a small practice, your electronic medical record system, what you keep your records in and what you bill out of, we are charged per claim to bill. So we have to repay for all of that to be done. So it is a burden. So
what the Senate Joint Resolution 54 report found, after the Department of Medicaid looked at that is they definitely saw that Kentucky was some of the lowest therapy rates among our peers. And the Department of Medicaid recommended targeted increases, not across the board, but in a targeted approach. So they had suggested focusing on the top 10 billed CPT codes and EPSDT. And then this just sort of highlights, we were really excited when we saw this because it showed that we needed increases in 2024. So then the budget of 2024 and 2026, House Bill 6, included a $25 million for Medicaid rebasing. Again, the funds were appropriated, but what I think happened, again, looking in from the outside here and sort of being in the middle, is the lack of specific direction, which I think created that gap. The cabinet did not utilize the funds, as we know, for pediatric therapy. The legislator believed, though, I think you guys believe, that those funds were going to support us as providers. And again, us as providers, we received mixed signals from both the legislators and DMS. I have multiple emails from DMS saying that they're working on certain things, getting pricing to us or getting pricing, and then back and forth. And so we've really been playing monkey in the middle. And here today just to really come up with a solution on how we can finally get this to the finish line. So our ask is really to be able to, protect our current network of providers. Of course, we would love what I think the nurses have, which is annual, if adjustment based on the increases, inflation. But our goal today is to do a 20% increase of these top 10 codes that we've listed here and the increase for the EPSDT rate so that we do not lose value against our current cost of labor increasing, rent, therapy equipment. Therapy equipment has gotten so expensive with the tariffs and everything else. It is so hard for these kids to get what they need. And then what we're also asking is alignment between the cabinet and the legislator. So to be able to execute what we need. So again, just looking at what does this cost, right? At the end of the day, what does this cost? We are thinking this is around, or based on the last budget, $36.2 million to $50 million being at the highest is the total budget for pediatric therapy services. And that's based on assuming it's a $22 billion Medicaid budget. If you look at that, it's a 0.045% of the total Medicaid spending budget. So at the highest level, we're thinking this would be a $10 million figure, but that's before federal participation. And so my understanding is once federal participation and matching dollars are applied, the state's actual investment is substantially lower than that, probably somewhere around $3 million.
And then in Kentucky, basically what you were saying in the previous slide, that $36 million annually, the overall Medicaid budget, specialized therapy costs are often hidden within the MCO buckets. So we still were able to see in that study recently those specific figures show the provider shortages and the rate disparities supports that. And then the therapy type annual spend, I think this is interesting looking at OT speech, PT, and the total spend. That's kind of how it's broken down, which is $14.8 million for OT, $14.3 for speech, and about $7.1 for speech therapy. And that does not include any of the services that might be provided like through a waiver, some of those extra waiver add-ons. And this slide kind of shows the spend.
So where are we right now? Commissioner Lee, last week I was able to talk to her for a moment, and she acknowledged that she made the recommendation in the Senate Joint Resolution for the need for increasing pediatric therapy. So she did acknowledge that there was a need. And she committed to me last week that she would be willing to meet with myself and any of you guys, any legislators, to discuss how can we really get this across to the finish line and what is needed from both parties. Josh, I think, is who also here. I got to meet with him, and he's engaged with us and just making sure we had the updated financial cost, because we've gave you projections, but it might not be exactly the number. And so I had emailed Josh, and he said he would work on getting that exact number for us, which is something we were promised 2 years ago as well, and we did not receive. So just making sure we have that exact data for you. And then again, we do believe the data is here. It's a solvable problem. We feel like it's very tiny in the overall budget. We know that it is, though, part of the budget. And so any increase we believe is going to help the children and actually receive the services that they need and continue to help our waiting list. And then this is what I'm so excited about for you to share.
Yeah, just the return on investment. Like, what would this mean? What would the outcome mean for Kentucky children? And this is where I think our hearts just bleed in this area, because we've seen with our own eyes. If you haven't known a child getting therapy or you haven't been close to it, it's pretty miraculous. It's pretty amazing what happens. And to take a child who's not walking or talking and without intervention would continue, maybe wheelchair bound their entire life. You all understand the expense that brings, the difference between getting a child out of a wheelchair and walking and upright, or the difference between a child who doesn't understand language or can't socially or emotionally connect to their parent. Getting that child moving along and now able to communicate, able to learn, just vast differences between intervention and non-intervention. And medical model is outpatient therapy is very different from school-based therapy. A lot of people are confused about that. They think, oh, kids get therapy in school. It's a different model. School is focused on school and the supports there. When you have an infant who isn't eating, that is the biggest stressor on a family. When their failure to thrive, they're not eating. It's the knowledge base of a pediatric therapist that takes that child from maybe perhaps a G-tube, a tube fed their whole life, to eating and not having to rely on that tube. So there are just incredible, it is an investment. It's not an expense, if you can think about it that way. So for every dollar spent on pediatric OTPT speech, the state saves approximately $4 in future costs for special education, long-term disability, lost tax revenue. We have watched kids learn to read, which isn't, we're not trying to teach that kid to read, but we're focusing on their language deficit, which then allows them to read. So the learning that happens in school is completely different when you can get to that early intervention. So increasing rates for those top 10 codes isn't about a provider raise or just for us and our practice. That's not what we're here for. We're here that it's a strategy to reduce the total Medicaid budget by decreasing the long-term acuity of the patient population. And we love our Kentucky kids, and we're doing this on behalf of the entire state that we would like to see this increase.
So just a reminder, we appreciate everything you guys have done for us, and we want to be very, we want to acknowledge that we are willing to do whatever with Department of Medicaid and with the legislators to make this year in this budget get to the finish line. So however we can help support, be a part of these meetings, I'm just ready to see everybody at the table to figure it out. And I am so thankful again that you've allowed us to come in here. And so we will end there and say, do you have any questions?
Thank you for your presentation. Sincerely appreciate it. And Ms. Marshall, appreciate you sharing your personal experience about how you came to Kentucky. And
yeah.
We would call that divine intervention.
It was like God wrote it on my mirror. I was praying for where to go, and he sent me here.
Well, glad to have you here. You mentioned 2014. Mark Twain said that when the world came to an end, he wanted to be in Kentucky because everything happens 20 years later. So you still got another 10 more years to go before we can address this issue. But not making light of this at all. But we have some significant challenges going forward. And wanted you to present today in large measure because Senator Adams and Senator Douglas and I are on the, and Senator Kerr are on the Medicaid Oversight Advisory Board. We got some significant challenges, and I think we could hear this presentation probably from every provider group in this state. Mm-hmm. And we're really struggling as how we're going to address these shortfalls as well, but it is our intention to try to do that. But it'll probably be more long-term than it is short-term. I don't say that to discourage you, just telling you we've got significant issues to deal with, particularly with the anticipated cuts from H.R. 1 that we're seeing. So we're trying to figure that as well. But I would hope and pray that we could give this priority. I think children should deserve the priority. Senator Carroll, you have a question, comment?
Thank you, Mr. Chairman, and thank you all for being here this morning. And this is a very complicated issue and one that I battled for many years as part of Easter Seals West Kentucky. And I know in recent years there has been a lot of confusion about where therapies rates were going, what was going to happen with EPSDT. At one point there was a plan that EPSDT would, the providers that do those services, provide those services, everyone would be able to do those. That rate would go away, but then the standard state plan Medicaid rate would be increased, and that was the way it was going to be addressed. And then nothing happened with that because apparently the money wasn't there to accomplish that. And the best when I left 6-8 months ago, whatever it was. And everything was kind of still in limbo as far as where Medicaid was going. And I think most members are familiar with EPSDT and the difference between an EPSDT rate and just the state plan rate for therapies. And not everyone is. You all might explain that before I continue.
Yeah, and I can also give a little history. Before the expansion of Medicaid in 2014, that was limited to be billed only by home health or hospital or by like an SCL entity, a community living support agency. And so it was limited there of who could even bill Medicaid. Like pediatric therapy couldn't bill Medicaid outpatient unless we were doing it through one of those licensed, or we had to be licensed ourselves as a CORF or something. So that rate, and at that time, there was a lot of home health. There were a lot of home health companies. Think about the health departments they employed therapists that would go into the home. And because that rate hasn't been touched in so long, it doesn't cover the cost of going into a home. Mm-hmm. It doesn't cover that anymore. So there's almost little to non-existent anyone going into the home to actually provide those services. There are educational supports through that Birth to 3 program, First Steps in Kentucky. But again, that's an educational model that isn't a medical model. So I think the history of some of that EPSDT was some of the more complex kids on waivers that were able to get those services and meet the needs.
Mm-hmm. And it's still federally mandated. So some of our therapists will go into pediatric facilities and do services like the PPEX and provide, and then they drive around and then go to the next facility. So, yep.
And Mr. Chairman, I say that because it is important to understand, and the way Easter Seals operated, I know there are other providers in the state that are similar, is, we were doing the EPSDT therapies, and those come at an enhanced rate. For PTOT and speech, it's $85.05 a unit. And, we contracted out with therapy providers. We took referrals. We would bring them in. We did all the PAs, all the billing, and then we had therapists at one point that would come to our center. Sometimes it was done at their center. And so that's kind of the way it was set up, and it's been very confusing over the years. A lot of issues with the billing codes dealing with EPSDT.
And the state has now updated that, so everything's been moved over.
Yeah.
So it has been clarified to the 9 codes. Yeah,
Okay.
they're no
So-
longer S codes.
Okay.
Yeah.
And that MCOs were drawing back money
Yep.
every chance they
Yep.
could and accusing people of fraud and
I think
everything
that will-
else
yeah.
for the code. So that's been
Yep.
resolved.
And it is an episodic, or it was billed as an episodic, meaning if you provided therapy to a child, the range was 30 minutes to 60 minutes. It was a range of time, whereas now, OT and PT are timed codes. And so moving toward that flat rate they took 3 9,000 codes and designated them, one for OT, one for PT, one for speech.
Yep.
It's still not fully implemented because the MCOs have not completely gotten on board yet. They're waiting till April 1st. It's been pushed back a little bit, but it'll
clarify a lot of those confusions.
Yes.
So it was like the goal was January 2026, and
But the important thing is that they would load the rate correctly for that flat rate, because here it gets a little confusing without going into medical billing. Some of you all understand many of our children have commercial primary, they have Medicaid secondary. When you bill commercial primary, you can't change rules, right? You have to bill the way you have to bill what you do. And then when that flips to Medicaid processing that payment, that's where it gets tricky, using these 9,000 codes, and makes it a little difficult depending on how the MCO system processes that.
And Mr. Chairman, and I'll close out. I think the point that finally what I want to make is that the issue, if a provider is strictly an EPSDT provider, and I can tell you from experience, and we were working with, I guess at some point over 1,000 kids. Financially, I can't complain about the money that the revenue we were bringing in at all with the EPSDT rate, and I know the state rate is less, and and I don't know where the cabinet is headed. You all know that better. I kind of lost track with that on what the current plan was, because it would change frequently. But I guess with the rates, in you all's practices, do you all do what percentage of what you do is billed through EPSDT?
I would say ours is maybe a quarter to a third.
yeah,
Is it? Okay.
yeah, and we don't get grants like Easter Seals either.
Right.
So we don't have any other funding other than.
Well, I'm talking strictly
Yeah.
revenue from
Yeah.
our therapy program, and
Yeah.
there is a significant difference in the rates that for those services that aren't EPSDT. But I do want to make that clear that that program brought in significant revenue for us, and it carried other programs with the EPSDT rate. And there was the talk was that was simply going to go away, and that every provider would be able to provide EPSDT services and meet those federal requirements, but that there would be a new rate that would be higher than what the current state plan rate is, and that was supposed to be the answer, the solution long term, and that just simply didn't happen.
Did not happen.
You're correct.
Okay, and so as it stands right now, and I just checked with my former CEO, and the rates are the same for EPSDT, and there's not any notification on what's going to change and if it's going to change. Everything has been in a holding pattern for a few years now. Is that still where we are as far as you all know?
Yeah,
Yes.
it is. However, the billing code is now switched to the 9,000 code. And out of curiosity, how long has that rate been 8505 that
Since-
you're aware of?
For us, it was since 2000.
I don't remember it ever going up
As long back
since
as
we would-
2010,
when
yeah.
MCOs started.
Folks, if we could, we're
I'm sorry,
4
Mr.
minutes away
Chairman.
from closing this meeting,
you're
and we
good.
always finish on time. We have one final question, so I'm sure y'all can continue the conversation offline. I would appreciate
Yeah.
that. But Senator Douglas, last question for you.
Thank you, Mr. Chairman, and I hope this only takes just a couple of minutes. Ms. Marshall, I know earlier you mentioned that the therapists now, part of the increased cost is that are they required to have a doctorate?
Yes.
Yes.
Okay. Is that DMS or Department of Medicaid Services
It's not.
that's
No.
requiring it? Who
it's
is
not.
requiring it?
It's licensure. Well, it's really the school programs, the education side, the higher education
So
has moved to that doctorate.
It's an
level.
academic process, is what
Yes.
you're saying.
It's an academic.
Okay.
If you want to be licensed in the state of Kentucky, you will have a doctorate.
Again,
And that's for
it's-
OT and PT.
Again, it's not a legislative process. It is an academic process.
Yes.
Correct.
Okay. Because one of the things I'm talking about now is how we're changing our academic processes. They are not legislative processes. Now, the second question I have, and you may not have any the answer to this. What percentage of the population, and this certainly is a really physically, emotionally, and financially challenging population. What percentage of the pediatric population are we talking about in terms of the pediatric population in general?
You mean what percentage receives therapy?
Correct.
18%
I was going to say about the same.
based on CON. When we had to do the CONs, it was around 18%.
Okay, so 18% of our pediatric population in the Commonwealth of Kentucky are receiving these services.
Correct.
Okay, thank you, Mr. Chairman.
Thank you.
Or
Just
would
closing
qualify.
comment. Obviously, we're going to. It's a budget year. I appreciate the input you've given us, and I'm sure you will give this a very, very serious consideration and commitment. We'll do the very best we can. But appreciate you being here. Very enlightening presentation this morning.
Thank you.
I also appreciate the attendance of all the committee members. Our next meeting will be Wednesday, February 11th, and unfortunately, again at 8 o'clock in the morning. So, with that, we stand adjourned. Thank you.
Thank you.